Welcome, everyone. We're just going to give it a little bit more time as people continue to join us. Hello, and welcome to the webinar, What's the Latest in Clear Cell Ovarian Cancer? I'm Maggie Alexander, the Senior Director of Gynecologic Cancer, Patient Support and Education at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. We have a few housekeeping reminders for you. All participants will be muted during the presentation. Once the speaker finishes presenting, we'll begin the Q&A discussion. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember that Dr. Brown is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. This webinar is being recorded. We'll share the recording in a few weeks with all registrants, and it will also be added to our website. Now, I'd like to hand it over to today's speaker to introduce herself. Dr. Brown, we're so excited to have you here today. So I'll hand it over to you now.
Well, thank you so much. I really appreciate that, Maggie. It's really an honor to be here today to join you all. So by way of introduction, my name is Jubilee Brown. I am a professor and the Director of Gynecologic Oncology at Levine Cancer Institute at Atrium Health in Charlotte, North Carolina. Like many of us in medicine, my path has kind of taken me into multiple places. I grew up outside of Cincinnati in Kentucky, went to Michigan State for undergrad, then Cincinnati for med school, then Maryland, spent time in Baltimore for my residency and 2 years after that. Then did my fellowship an embarrassingly long time ago at the University of Texas, MD Anderson Cancer Center. And I was there for a total of 17 years as a full professor, finally, which was wonderful. I loved my time there. 8 years ago, I came to Atrium Health, to Levine Cancer Institute. I've been here ever since, and that's been just a wonderful, wonderful move. I have a fantastic team here. I do a lot sort of nationally, both and internationally, both with the AAGL, with a focus on minimally invasive surgery, as well as with the Society of Gynecologic Oncology, the International Gynecologic Cancer Society, and the NRG Oncology. So that's really what's probably most pertinent today, because my real research focus is in rare tumors. And as you know, clear cell carcinoma of the ovary is absolutely a rare tumor. I'll share with you the really great news that it's getting a lot more press and attention now, which means, that's good news for every single person on this webinar today. So I'll go ahead then and start. Yes.
Yes. Perfect.
Right. Fantastic. I'm going to share my screen. All right. And Maggie, you'll tell me if there's anything that's that I need to change, right?
Yes, it looks good.
All right, sounds good. So let's talk about what is the latest in clear cell ovarian cancer. So these are my disclosures, really none of which are relevant today. But today what we'll talk about is current trials and progress in clear cell carcinomas of the ovary, and we'll really talk about therapy that's utilized to treat clear cell carcinomas of the ovary. I show this picture of zebras and horses because so many times when someone hears that they have ovarian cancer, they log on and Google ovarian cancer, and literally nothing of what they Google is pertinent to specific rare tumors like clear cell carcinomas of the ovary. So in some ways, that clear cell cancer is a zebra in a Google world of horses. So I'm really excited to be able to share the latest data with you today. I think it's really important that there are so many facets of taking care of women with clear cell carcinomas of the ovary. Part of it is the, boots on the ground, what we do in terms of surgery. So we'll talk about surgery. Some of this we teach. So it's really important in your team of doctors to recognize that you're going to meet a lot of people, right? You're going to see a whole team of people who are taking care of you. Some of them are residents, some of them are anesthesiologists, some of them are nurses, some of them are chemotherapy coordinators. Really, we want to share all of this information worldwide. On the right there, you see a fellow that we had who was from Eurasia, who came and spent time with us. Sharing information about rare tumors is really key. And as I like to share, one of my mentors, Anil Sood, said, good research tells a story. And I would say sometimes it takes a while. For me, it's taken a lifetime to generate this, and a great team. And you see some of my really wonderful teammates there below, along with some of the things that we've published. So I want to give you a little bit of an overview through time, because really when we think about the work that's been done with rare tumors, including clear cell carcinomas, it's really relatively recent. So when I finished my fellowship back in 2002, all of the rare tumors related to the ovary were all lumped together. So literally none of the information or even the trials were specific to rare tumors, and certainly that's true for clear cell carcinomas of the ovary. So before 2005, all rare tumors that were included in phase 2 and 3 trials were included without regard to histologic subtypes. What that means is that every bit of ovarian cancer was treated the same. And we know now, boy, that is not right. So in 2005, my mentor and chair at the time at MD Anderson, Dr. Gershenson, chaired the first rare tumor working group in the Gynecologic Oncology group. Now the GOG, the Gynecologic Oncology group, now noted as the NRG Oncology, the GOG is the cooperative group. So when you have tumors or cancers that are relatively rare, you need a way to make progress, right? You need a way to bring people together to have these conversations and to study these tumors. So that's what a cooperative group is. And so within that gynecologic oncology group, we started the rare tumor working group. And so I've been a part of that since 2005. The international group, the GCIG, subsequently endorsed this approach. And, it seems like a no-brainer now, but at the time, this was really kind of a revolutionary concept to pull out these rare tumors and say, you know what, we can study these. We can actually look at these separately. The next year in 2011, the National Cancer Institute endorsed this at their clinical trials planning meeting. And that was really, 6 years of work here went into being accepted at a nationally funded level. And at that point, the working group transitioned into a full committee, and that's where we are now. We are able to do hypothesis-driven research in rare tumors. And what we've shown is that we can actually study these novel, new agents. We can use statistical design so that we don't have to have hundreds or thousands of patients to see if new medication is useful. And we can learn more about the tumors because we can do more than just look at patient outcomes. We can study really the detailed components that determine why something might or might not work. This all culminated last year. We brought together an NRG preclinical workshop, and we'll talk more about that, really about how to make smart decisions for what to look at, bringing the smartest people together who are really invested in studying these rare tumors like clear cell carcinoma. this all led to a book that was just published, last weekend, looking at 50 years about transforming the standard of care, and really about how the Rare Tumor Committee has made some strides, and I'll share all this with you today. So really what we're seeing is a lot of progress and success. And I think this is so important for every single person who's on this call, because you need to know that your tumor is being studied. In this workshop that we held a year ago, clinicians, so doctors and scientists, people who were, PhDs and running their labs, and pharma all came together to talk about, opportunities. What we found is that there's an abundance of molecular and targeted agents and ideas, but in the past, there really haven't been very many preclinical models. We haven't been able to study it in animals because we haven't had models to, grow these tumors outside of a petri dish, right? And especially with rare tumors, these things were very difficult to study. But it turns out that there are key people who are interested in this. And so now we have working groups specifically dedicated to rare tumors, and there is a working group for clear cell carcinoma within NRG Oncology. So this is great. The reason this is so important for making progress that's relevant to you is that in the past, the Rare Tumor Committee had a whole lot of great concepts that were submitted, but we didn't have enough preclinical data to get funding to move forward on a national level. And so what we did was bring all these people together, including the leadership of the NRG Oncology and the NCI, the National Cancer Institute, to make sure that we were doing this right. We now have a process where people who are interested in devoting their careers to clear cell carcinoma can work together to gain models and drugs for preclinical evaluation. So basically to give us the information that we need to move forward from a research standpoint. Now, really important, this workshop was meant to be the starting point. And interestingly, pharma is not a bad guy here. Pharma is really interested in this. They a lot of times do this background work behind the scenes that bring these drugs to the point where they become available to patients. And so instead of reinventing the wheel, we can actually work with pharma to gain the information that they've already developed. So this is really great. And that leads me to talk about specifically clear cell carcinoma. So when we think about ovarian cancer, I mentioned that it's very different than other types of ovarian cancer. And it turns out that when we look at all the different types of cancers that develop from the ovary, there are basically 3 types. So what you'll see, you can see my little pointer there, I think. So the first sort of bucket of tumors is called germ cell tumors. These develop from the eggs in the ovary. The second sort of bucket is called sex cord stromal tumors, and that develops from all this sort of supportive tissue that makes up the bulk of the ovary. But what we're interested about today is the epithelial ovarian cancers. Okay, so that lining tissue is called the epithelium, and that is what leads to epithelial carcinomas, and specifically to clear cell carcinomas. So things like low-grade serous, mucinous, clear cell carcinomas, those are rare ovarian cancers. What you see at the top of the screen, the high-grade serous, those are the common cancers. And so when you Google ovarian cancer, generally speaking, what you're going to get is information about specifically high-grade serous carcinomas. What we're going to talk about today is the clear cell carcinoma. So these are very different. They have distinct histology, meaning they look different under the microscope. They affect different groups of people. We call that epidemiology. They have different characteristics, so molecular biology, and they act differently, so clinical behavior. It's all very distinct from other types of ovarian cancer. And interestingly, only about 1 to 12% of all ovarian cancers in Europe and North America are clear cell carcinomas. But in Asia, and specifically here in Japan, 25% of all ovarian cancers are actually clear cell carcinomas. So this represents a real opportunity to partner with our international colleagues so that we can really learn more about how to effectively treat women with clear cell carcinomas. They do have some different clinical characteristics, more clots and higher calcium levels, really common with clear cell carcinomas. This is what it looks like under the microscope. And this slide is courtesy of my friend Keiichi Fujiwara in Japan. So when we look at these, they have very specific characteristics that help the pathologist identify what is a clear cell carcinoma. So they have estrogen and progesterone receptors. So that actually is a therapeutic target. We can block those receptors specifically for some clinical activity to block the progress of the cancer. And these other things, the WT1, HNFS1 beta, napsin, those really help the pathologist identify these cancers as specifically different from other types of ovarian cancers. Who gets clear cell carcinoma? Generally speaking, these tumors happen earlier in general than more common types. So they affect women in their late 40s and 50s, generally. Of course, there are exceptions to that rule. Many of these clear cell carcinomas of the ovary are early stage, so they often haven't spread outside the ovary. And when that happens, that's better in terms of outcome we call prognosis. Many times we can do fertility sparing surgery. So in case there's a young woman who wants to have children, if that cancer is limited just to one ovary, we can sometimes save the other tube and ovary in the uterus. So we call that fertility sparing surgery. But we do still sample elsewhere to make sure it hasn't spread. And because these cancers are honestly so aggressive, we consider treating even patients with the earliest stage of cancer, so stage 1A, because they are all by definition high grade, meaning kind of angry looking under the microscope and clinically more aggressive than other stage 1A patients. Even now, our sort of standard of care has been a taxane, so paclitaxel, docetaxel, and a platinum agent. That's pretty much standard for most patients with ovarian cancer, at least epithelial ovarian cancer. That's true for clear cell cancers as well. Interestingly, in the Japanese studies, where remember we mentioned that women who have ovarian cancer have a lot more clear cell carcinomas, the outcomes are great, even with observation in stage 1A. So there may be a role, at least in that specific population, for observation. That is not typically what we do here in the United States, and it is not really within the NCCN guidelines at present. However, that may be an opportunity to kind of scale back on therapy moving forward. Unfortunately, when patients are diagnosed with clear cell carcinomas at a late stage, the outcomes tend to be worse than the other subtypes of ovarian cancer, because when they're in a late stage, they tend to be resistant to platinum. Now, not always, and so again, the platinum and taxane upfront is the standard of care, but we need to expect that we may have to do some more therapy. Patients may not respond quite as well. So let's talk a little bit about surgery. Surgery is typically the very first part of treatment. And it's really important in young patients who still wish to have children that we have a discussion about fertility beforehand. Now, historically, we would make a big up and down incision, squirt some saline in and suck it back out again, and then spin it down to look to see if there are any cancer cells in that fluid. USO means unilateral salpingo oophorectomy, meaning we take out the tube and ovary on the affected side. Okay, we send that off to the pathologist so that they can look at it at the time of surgery and tell us what we have. And if they see a clear cell carcinoma, we absolutely have to take additional biopsies to make sure it hasn't spread anywhere. That whole process of taking those samples is called staging. Now, in patients who do not want children any further, the absolute thing that we do is take out the uterus and cervix, both tubes and ovaries, and any visible cancer that we see. So that would be considered a complete hysterectomy, people call it that. In patients, again, who have just one ovary involved, apparently, that's what it looks like at the time of surgery, then there may be a role for taking out just that tube and ovary and doing the staging. So MIS means like laparoscopy or robotics. So now that looks to be an option for women who have early stage disease. So that's been another advance. So again, with regard to fertility, we can, if it looks early, we can usually spare one tube and ovary in the uterus. And with the help of our colleagues in reproductive endocrinology and infertility, sometimes we can harvest some eggs and patients can, as long as they do well, subsequently have children afterwards, even with the diagnosis of ovarian cancer. Now, it's a very specific and specialized situation, but it is something that, you know, is increasing when we're lucky enough to find these carcinomas early on. This idea of fertility sparing surgery has been published and is actually involved in the NCCN guidelines. So that's sort of like a summary about clinical care. Now let's like dive in a little bit deeper to some of the more esoteric science, if you will. So when we talk about molecular biology, what is that? So many of you may have had your cancers sent off to a lab where they do more than just say this is a clear cell carcinoma, right? What we can do is actually look at the molecular features of the cancer cells, and we can see from a DNA standpoint what kind of mutations are present. Well, it turns out that in clear cell carcinomas, about 40% of patients with clear cell carcinomas have these PIK3CA mutations in the tumor itself. Now, that doesn't mean that you necessarily inherit it. It means that within the tumor, that's like the personality of the tumor. And that's important because we can target that mutation. That means that we can really, we can sort of make smart decisions about what kind of medications might work to best treat patients with clear cell carcinoma. So what you see here is the way that this works. In other words, what is this thing about PIK3CA? What is it responsible for? Well, so basically, it's the computer program that directs your cells what to do, right? We have lots of these computer programs running in our bodies, right? But PIK3CA is part of this pathway that helps cells know how to divide. And so basically, if this is your cell surface, the surface of the cancer cell, you have a receptor here that can activate this PI3 kinase. And basically that sets up this cascade of signaling that goes through the cell that drives cell survival and division. So if you can target this, you can kill the cancer cell. I hope that makes sense. So basically, we can target this PIK3CA mutation by targeting PI3 kinase and AKT. We also have a separate class that's further downstream called mTOR inhibitors like everolimus. So that's why we know that these medications are useful to look at to see if we can really impact women with clear cell carcinoma of the ovary and kill these cells. It also looks like angiogenesis inhibitors may be useful. So what is that? That means basically, you know, cancer cells need oxygen and they need nutrients because they're dividing super rapidly, right? So the reason they're cancers is because they grow out of control, right? So they need lots of energy and oxygen to be able to do that. And where do we get energy and oxygen? Well, from blood vessels. So we get new blood vessels that form that supply the cancer cells. And so if we can block that, then we can basically choke off the tumor. Hope that makes sense. So these are the list of different angiogenesis inhibitors that have been studied. And most recently, we looked at sunitinib and nintedanib as opportunities for drugs that might work by blocking off those new blood vessel formations. Unfortunately, sometimes these things sound better than they actually work. So we looked in the GOG, we looked at sunitinib and GOG 254, and unfortunately, only 2 of the 30 patients who were treated responded. So we we called this minimal activity, of course. It's not that it never worked, but not enough to really justify looking at it further. We also looked at temsirolimus, which is an mTOR inhibitor. You remember on that pathway, targets that bottom part. So we looked at this at GOG 268. So it was this drug called temsirolimus with the sort of standard of paclitaxel and carboplatin, and then followed with temsirolimus. And here we pulled in our partners from Asia and included patients from Korea and Japan. And what we found was that there wasn't really any difference in the groups of patients, whether they were US, Korea, Japan. They sort of did the same. And treating with this intensive regimen did not make any difference in terms of what we would expect based on how we know patients do. So to drill down on this a little bit more, PFS, when you hear PFS like here, that stands for progression-free survival. It means, does the cancer come back? And overall survival, it essentially translates into cure rate. We looked at satinum, and now this is a pill that you can take, okay? And that pill basically targets the very initial cell surface area. So it's a tyrosine kinase inhibitor pill that you can take. We looked at this in multiple types of clear cell carcinoma, so not just ovary, but also tubal, peritoneal, uterine, or endometriosis associated clear cell carcinoma. And we wanted to know, a lot of these tumors are ARID1A positive. That means that the sort of the personality or the signature of the tumor shows up for ARID1A, and we can interrupt that with this dasatinib. Unfortunately, again, you know, sometimes these things look great on paper or by an idea. This just did not work at all. We tried this on 13 patients with 0 responses, so the trial was stopped. I think that's an important point. All of these trials are designed to treat the fewest number of patients to get the answer. So if something works, we want to know it early on so that we can, you know, offer it to more patients. And if it doesn't work like this, we do not want to treat even one more patient beyond what's necessary to know that this is not a useful drug, right? So please know that for any clinical trial that goes through, the statistics are really carefully crafted to get the answer as fast as we can. We also looked at pembrolizumab, which is immune therapy, and epacadostat, which is an IDO1 inhibitor. It's a different class of drugs. And here we got 14 patients that were treated really rapidly with a response rate of 21%. 3 patients responded well. And unfortunately, even though this met the criteria to say, hey, this might be an active drug, we need to, you know, study it further, the company decided not to pursue the trial anymore. That IDO1 inhibitor was no longer produced. So this is unfortunately reality of what can happen in this setting. So sometimes, you know, even though there are great ideas like this and it starts to look really good, unfortunately, the pharmaceutical companies can decide not to pursue an agent, and then we don't have access to it, so we can't look to see if it works any further. So yeah, are you kidding me is my answer to that, but that is unfortunately the reality. We also looked at cabozanib in patients. That's another type of small molecule inhibitor. It did not work, and it led to some blood clots, 5 thromboembolic events. So we did not pursue this further. Now, it's not all bad news. We have a lot of trials that are ongoing, actually. So there's GY014, which is looking at tazemetostat, and enlotinib, the ANI trial, along with a PARP inhibitor. So this one here, this was actually published out of China. And this actually showed really promising results. This small molecule inhibitor and a PARP inhibitor, which we use in other types of ovarian cancers. There's also immunotherapy that's being looked at in clear cell carcinoma, and I'll talk a little more about immunotherapy in just a minute. Also looking at nintedanib, and to other drugs that are related to immunotherapy. So you've heard me say immunotherapy a couple of times. So let's talk about that. So what is that? Basically, immunotherapy is not chemotherapy, okay? With chemotherapy, we're actually trying to kill the cells directly, right? By essentially by virtue of the way that the drugs work, right? They'll interrupt the cell processes and the cells die. Basically because some sort of machinery inside the cell is disrupted, right? And unfortunately, that's what leads to other side effects from these drugs too, because they can target not just the cancer cells, but normal cells too. Well, immunotherapy works differently, right? Immunotherapy basically revs up your own immune system. So it accelerates it and it takes the brakes off of the inhibitory portions of that. So revs up your immune system so your own immune cells can attack the cancer. The thing is, your immune cells that you have floating around in your bloodstream, they have to be able to recognize the cancer. They have to be able to say, aha, this is a cancer, this is bad, I'm going to go kill this cell. So, so we cannot necessarily change whether our immune system can see the ovarian cancer. But what we can say is with clear cell carcinoma, much of the time, the immune system can see that. And I'll show you, this is really cool, actually. So Hamanishi initially showed their work on this. They looked at immunotherapy in all-comer ovarian cancer, not just clear cell carcinomas, okay? But they looked at 20 evaluable patients who received either low dose or higher dose nivolumab, which is immunotherapy. And they saw 15% response rate, but it also kept patients from having the cancer progress. So that's called a clinical benefit rate. If you get either a response or the tumor doesn't grow, so stable disease, that's a benefit, and that's called a clinical benefit rate. Well, interestingly, there was a clear cell carcinoma in one of the two patients who had a complete response. A CR is a complete response, okay? So basically, this patient with clear cell carcinoma on this trial, the cancer went away, right? Completely gone, okay? And we see this here, okay? This patient had a complete response to treatment. And it was a rapid response. If you look here, like literally within 3 months, that tumor went away completely. And it stayed gone. Look at this, up to, almost 400 days later, right? That's great. So how do we know if something's going to work? Well, we have a lot of different tests that are out on the market right now to look and characterize cancers, right? Some of them are called tumor molecular burden. Some, your pathology report will say microsatellite instability high, or we can look for the PD-L1, which is the sort of marker on the ligand, the marker on the cell itself. And so we can see that there are like lots of different combinations. So you can't necessarily just look for one of these. You actually have to look for all of them to see if you're likely to respond to immunotherapy, right? So addressing multiple markers of immunotherapy sensitivity allows you to find which patients may benefit, and it keeps you from excluding somebody. So just in like normal language. So if I see a patient and I want to know, should I treat this person with immunotherapy? Well, I'm going to look at all these different markers. I'm going to look at TMB, MSI, PD-L1, because I'm going to want to know, I'm not going to want to miss the opportunity for immunotherapy, right, to have that work. It's important, though, that I don't just randomly treat people with immunotherapy if they're unlikely to benefit from it. So this combination of tests helps us know how we should treat patients. And so that's where comprehensive molecular profiling comes in. There are lots of companies that assess cancers for this, right? You've probably heard of Foundation, Caris, Tempus. I mean, there are a number of different ones. And we lump that together, calling it comprehensive molecular profiling. It gives that signature of the cancer cell. And it basically allows us to base treatment on more than just saying clear cell carcinoma. We can base treatment on that like the individual person's cancer and those characteristics. And so what I'm going to show you is that you can get dramatic responses in women who have cancers that don't respond to anything else. So this panel testing allows us to measure these levels of genes or gene products, and really almost gives us like a biomarker of response. It can tell us what's going to work, and it can tell us potentially what's not going to work. So this is a patient. So when I first moved to North Carolina, like 7 years ago, I saw this patient who had been treated by one of my partners before, 57-year-old woman with recurrent stage 1A clear cell carcinoma of the ovary. And she had been on like everything. She had been on standard paclitaxel carboplatin. She'd had surgery. She actually was had an EGFR mutation, and so she was treated on the TAPER trial. She did not respond to cetuximab, and then she we tested her, and she was PD-L1 positive. And what you can see, this is called a PET CT scan. You can see this really bright lymph node that shows up. She had some other areas of disease that you can see here too. Those bright spots are abnormal. 6 months after she was treated with immunotherapy, nivolumab, based on that PD-L1, you can see it's gone. And she is absolutely doing great. No evidence of any disease even now. So this is how like that kind of information can really guide therapy, and you get these incredible responses, and it's just amazing. Now, so why can't we just treat everybody like that, right? Well, what we looked at, and this has been, I presented this a couple of years ago, but we're updating this and look to hopefully publish this in the near future. Not every clear cell carcinoma of the ovary is the same, okay? And so looking at all of the samples that have been evaluated by Caris, what you can see is like ARID1A mutations occur in about half of patients with clear cell carcinomas, okay? And that's targetable. You can treat those patients with EZH2 inhibitors, right? PIK3CA mutations, again, present in about half, and that's targetable. And what you can see is that there are other mutations that are targetable, even like BRCA mutations. They show up sometimes in clear cell carcinomas. So, you know, you don't want to miss knowing that's there, because you can use a PARP inhibitor on those patients with a likelihood of getting a response, right? That said, you wouldn't want to use a PARP inhibitor on the other 98% of patients, because that would just be random, right? We don't want to use something that's unlikely to work. But I think that the key here is just to see that there are so many different potential opportunities that are individual, so that personalized medicine becomes really important. And what we can see is that there are targetable mutations in all these different kinds of rare tumors, and you just can't generalize because they're all different. I hope that makes sense. So I mentioned we presented this. There are a variety of actionable mutations, meaning druggable targets, things that that the medications that we have may work on across all the different types of gynecologic cancers. And so my recommendation is that molecular profiling is a really important component of treatment to identify potential targets. And this whole idea saying like, we need to know what your tumor looks like. We need to know what characteristics a specific person's tumor looks like so that we can target that. You know, we started thinking about this. Well, this is the way that we should be studying cancer, right? So for example, this is a concept that came out of the you know, I said a year ago we had in the NRG, we had the retreat, the workshop, and this concept actually came out of that. So the clear cell working group worked to identify that there is a loss of function mutation here, this PPP2R1A mutation, and we have drugs that can target that. So the combination of durvalumab and tremelimumab, try saying that 5 times fast, durva and tremi, can work to target this. And so Dr. Lin is in the process right now of working up sort of a variation of this concept that was presented. And further, we have the Bouquet trial. And so I'm on the steering committee of this, and I'm very committed to this way of studying tumors. So basically, every single patient with a rare epithelial tumor, including clear cell carcinoma of the ovary, is eligible for this trial. If the cancer comes back and platinum doesn't work, so platinum resistant, there is an arm for you. This is really important because instead of just, what you saw before, randomly sort of selecting a drug and saying, oh, let's try this in everybody with clear cell cancer. Well, we know that there's a better way to do this. And so what we do is take a sample of the tumor, we run that testing on it. In this case, it's through Foundation because they've partnered with Roche to do this, Genentech Roche to do this. The tumor is tested, and then based on the results, patients are offered a treatment that they wouldn't normally have access to, and it's based on the mutation, like the personality of the tumor. So for example, if somebody has, we talked about PIK3CA mutations, well, guess what? There's this arm, I can never say this, inavolisib and palbociclib. So you can get this arm, and if you don't have that mutation, but let's say your estrogen receptor is positive, well, guess what? Then you can get inavolisib with palbociclib and letrozole. And let's say that unfortunately your tumor doesn't have any of these characteristics. Well, we have a non-matched arm. So we have inavo plus olaparib. So it's I think at least a much better way to study these tumors. And again, it's not studying for us, right? This is studying these tumors for you. It's to figure out what works to cure this awful thing called clear cell carcinoma of the ovary. And so the bottom line, I think, is we have to keep working on this. We want to keep pushing, keep looking at treatments that may be more successful than what we've had in the past. And the more we can make inroads into this, the better the outcomes will be for all of our patients and for you. So just to let you know, this is my family. So the thing that I have raised them with is, I don't care what you do in life, just leave a positive footprint in the world. And that's certainly what we're trying to do here. Fortunately, I'm blessed with just a remarkable team here at Atrium Health. I'm including my contact information, and please do feel free to reach out to me. Email is probably better than my cell, but I'm always happy to answer or be available. So with that, I'll stop sharing my screen, and I'm happy to chat through any questions that you might have.
Great. Thank you so much, Dr. Brown, for that wonderful presentation. And it looks like we have a good amount of time for Q&A, which is awesome. So let's dive in.
All right.
You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. Okay. So this first, we got a couple questions about NGS testing. And so this one is, which test is best to assess all of the immunotherapy response markers?
So that's great. So honestly, any of the commercially available NGS tests, and I mentioned several, they are all excellent. They're all CLIA certified and approved to look at the immunotherapy response markers. So yeah, whether you use any of the things that I mentioned, those panel tests are excellent. And As long as it is comprehensive molecular profiling, you'll get the answer that you're looking for.
Okay, great. Thank you. And then another question is, when should that testing be done? Should it be done before first-line chemo or only if a patient recurs?
That's a really excellent question. And so yeah, that's a very thoughtful question, because we don't have an absolute answer for that. So I would say that many of us will send this testing off immediately. I certainly do. That's our group's practice. And the reason is, so for every patient with ovarian cancer, at the time of diagnosis, we send both genetic and genomic testing. That is, we send off like a blood sample to look to see if there's any inherited mutation that, number one, is responsible for the cancer that you might develop, and two, is something that might necessitate other screening for cancers that you might be susceptible to. It also lets you know if anybody in your family needs to be screened or followed more closely. And is there anything that might be targetable? So like, for example, a patient who has ovarian cancer who has a BRCA1 mutation, unusual in clear cell carcinoma is true, but it can happen. And if that's the case, then you should be on a PARP inhibitor after your upfront chemotherapy, right? So that's really important. That's the germline part. That's hereditary. We also send off the NGS, so genomic testing, molecular profiling on the tumor itself at the first time of diagnosis, because of all these things, right? We don't want to miss an actionable target that specifies your specific tumor situation. Now, let's say that it's been 5 years and God forbid you recur. Well, then many of us think it's probably worth sending off that, if you have a specimen from that time when your cancer comes back, then it's probably worth sending that as well, in order to get a complete answer to say, has anything changed? What's specific to this clone that's somehow started to grow back?
Great, thank you. And so we have a lot of international people viewing today. So there's some questions about whether, are there trials worldwide available for clear cell ovarian cancer?
Yes, that's great news. Actually, yes, there are trials that are open worldwide. Now, not every trial is going to be open worldwide, and so sometimes it is hard to run these across international lines, actually. So I see a question like, is the Bouquet trial available in Canadian cancer centers, for example? So no, Bouquet, I do not. There might be one site in Canada, actually, but Bouquet is open in multiple European sites. It's open in, I think, 16 US sites now. There are other trials like the Annie trial that was just in China. So, there are a number of different trials that are open in different locations. If you go to clinicaltrials.gov, they have a comprehensive listing really of worldwide trials. So that's really the best place to go, I think, for a reference listing of all the trials that are available. And it does include non-US trials. The other thing is, if you're in Europe, GCIG, Gynecologic Cancer Intergroup, GCIG, they also have a listing of trials that are available there. But yeah, clinicaltrials.gov is probably your best resource.
Great, thank you. And then we're getting a couple of questions about recurrence. And so, is there anything you recommend to prevent recurrence after being NED?
So I wish we had the answer to that. If we could prevent cancer from coming back, that would be amazing. I would say excellent follow-up. And although that won't prevent the cancer from coming back, it'll help detect it at the very, very earliest possibility. And so I would say follow up with your doctor, according to the sort of the guidelines every 3 to 6 months for 5 years, and really be alert to your own body. I would say, and what I tell my patients is, if you have any symptom that's present most days out of a 2-week period, don't wait for your next appointment. Call me, message me. I want to know, because that's not normal. And it might be anything, it could be a cough, it could be a funny pain, indigestion. Like, everybody gets these things from time to time, right? But if it lasts most days out of a 2-week period, we need to look.
Mhm. And more questions about recurrence. So this person's saying that they've read that surgery isn't recommended in a recurrence. Does it depend on where the recurrence is located?
Yeah, that's a great point. And that's changing a little bit, I would say. So in general, ovarian cancer treatment of recurrence is different than some other types of recurrent cancers, because ovarian cancer recurrences tend to happen in multiple spots, right?
Mhm.
And so in that circumstance, which is the most common way that these cancers recur, we're not going to recommend surgery typically, because we know that you're going to end up needing chemotherapy or other therapy after. And all that more surgery is going to do is slow you down in getting that therapy that you need. Right now, if it's been a really long time since your initial therapy is completed, if it's in just like 1 or maybe 2 spots, and if we think we can completely resect that area, that's the time that we would consider surgery in a recurrent setting. Or I would say now, if now that we have like sometimes immunotherapy, let's say that you're on immunotherapy and it works to shrink down everything but maybe one teeny little spot, well, then I would consider going in and getting that teeny little spot, right? But that's different from standard saying, okay, recurrent disease, operate. It's not like that.
Okay, great. Thank you. And this person is asking whether fertility sparing surgery in early stage clear cell carcinoma, does that have like the same, outcomes as radical surgery? Like, so is it a safe
Yeah,
option?
it does look like that. So again, this is very limited. So in patients who have a stage 1A tumor that's completely staged, so stage 1A, meaning only in, the inside of one ovary, and a full staging procedure is negative, like has not spread anywhere, then yes, it looks like fertility sparing surgery is appropriate and has the same outcomes.
What about like 1B, 1C?
No. So if
No.
it's spread beyond at all, like if there are surface excrescences, I would say it's perhaps a little bit controversial, but really we try and limit that fertility sparing surgery to the very earliest of stages.
Okay, great. Thank you.
Because we don't want anything bad to happen, right?
Right, you don't want it to potentially spread.
Right.
And this person is asking, well, there's some questions about maintenance. So I guess so PARP inhibitors, if there is that BRCA mutation, could be used as maintenance, but there are some questions about the possibility of immunotherapy as a maintenance option.
Yeah, that is a great question. And so, as we mentioned, immunotherapy can really be incredibly useful for these patients, and it doesn't always correlate with PD-L1, right? So there's no perfect marker in this situation. So I did see a question in here that, to make sure that people weren't excluded from immunotherapy. You're right. It's a very, it's a challenge, right? Because you don't want to give something that's not effective, but you don't want to miss something that is effective. And that's where the difficulties come with maintenance therapy. So for example, we know in uterine cancers that maintenance therapy with immunotherapy can be incredibly useful, right? But we just don't have data with clear cell of the ovary at this time to suggest that should be standard. So you know what, that may happen in the future. That's like that whole study that I showed with temsirolimus with paclitaxel carboplatin followed by temsirolimus maintenance that tried to get to the maintenance question, albeit with an mTOR inhibitor. But that was the idea, that can we keep this from coming back? Well, certainly when you have a BRCA or a BRCA-related mutation or homologous recombination deficiency, and that's a little outside the scope of today's discussion, but yes, you could use a PARP inhibitor in that circumstance. That's less common with clear cell compared to like a high-grade serous situation. But if you happen to have that, if you happen to be HRD, homologous recombination deficient, or have one of those mutations, 100% you should be on a PARP inhibitor.
Great, thank you. And we're getting so many questions. Okay, so this person is just asking, I know you talked about this earlier, but I think there's still some confusion about what clear cell is. So this person is saying that is a clear cell epithelial. So could you just sort of reiterate that?
Yeah, thank you so much for asking that, because to be honest, many physicians, even many physicians get confused with this terminology. So I am very happy to say this again. It's a lot, and it's a lot of words that you don't normally use in normal language, right? So if you take all of the ovarian cancers, there's 3 buckets, right? 3 big categories for the types of ovarian cancers that depend on what part of the ovary they come from. If the cancers come from the outside covering, then those are epithelial. And there are 7 different types of epithelial cancers, one of which is clear cell. Hopefully that makes sense.
Great, thank you. And then we're also getting some questions about the connection between endometriosis and clear cell, and how that's different from endometrial cancer. So I'm also wondering if you could just briefly clarify that as well.
Yeah, I love that question. That is a very smart question, because I didn't really talk much about that. So endometriosis is sort of where the lining of the uterus. So remember, we have our uterus or the womb, right, where babies would grow. And the lining of that is called the endometrium. Then you have tubes and ovaries out on the side, right? Well, so sometimes that lining can go, we think most of the time, go out the tube and land in the pelvis, sometimes on the ovaries, and start growing, right? That's endometriosis. It's where that lining tissue is growing outside of the lining of the uterus. That's endometriosis. Sometimes you can have an endometriosis associated cancer, and clear cell carcinomas are often endometriosis associated cancers.
Great. Thank you for that. And then this person is asking about whether outcomes are better for later stage if the cancer is platinum sensitive.
Yes. So platinum sensitivity versus platinum resistance. In general, if somebody has platinum sensitive disease, yes, outcomes are better than if somebody has platinum resistant disease. What that means is, we never know for a given person if somebody's going to respond and live for a very long time, or if they're not. But if you take a group of people with similar characteristics, we can, in general, anticipate whether somebody has a better chance of responding to treatment. Also, people who respond to platinum or have recently responded to platinum, or have responded to platinum and it's been a really long time since their cancer has come back, tend to do better than somebody who got platinum and either didn't respond, like grew through it, that's platinum refractory, or somebody who had platinum and then it like came right back within 6 months, that's platinum resistant. So somebody who's platinum sensitive, in general, has a better likelihood of responding to treatment than somebody who is platinum resistant.
Great, thank you. And then this person is asking about whether HIPAC is a good option for clear cell.
Yeah, I wish I had the answer to that. Well, I would love to know that. And actually, so we're many places, in fact, our partners at Wake Forest University are looking at HIPAC. We're actually considering in the NRG HIPAC trial right now. HIPAC is heated intraperitoneal chemotherapy. So the idea is that you have surgery and then you put in hot chemotherapy, let it sit there, and then perhaps there will be a better response to treatment than just IV chemotherapy. There's one trial that looks at sort of all-comer ovarian cancers that shows an improved outcome but that's just one trial, and it wasn't specific for clear cell carcinomas. So I don't have the answer to that question, and I'm hopeful that, we'll be able to answer that in sometime in the future.
Great, thank you. And so I only have enough time for about one or so more questions. So just looking through, we did get a couple of questions about the use of radiation therapy for clear cell. And what are your thoughts on that?
Yeah, so I would say that, the way that radiation works, the principle is that it works wherever the beam of energy shines, right? So if you have a spot, like one little spot of cancer that typically is not surgically accessible, or if if it's causing you symptoms, radiation can work, right? And so radiation certainly can work to shrink that down or even make it go away in a specific area. I would say that is, if somebody has more widespread disease, radiation is not the treatment of choice, because again, it only works where that beam of energy shines. And in that case, you're going to want something that's more systemic and gets everywhere. This brings home, though, the point of personalized therapy. Every patient's different. Every sort of patient's cancer pattern is different. And so that's why, it's really important to personalize that cancer recommendation, the treatment recommendation for an individual person. And if I would say that if you don't understand what's being recommended for you, if you have questions about it, ask your doctor and have them really drill down into the details of why they're making the choices or the recommendations that they are.
Great. I think that's a great place to end on is, if you have questions, ask your doctor. And if you are wondering about different treatments, ask.
Right.
So thank you so much, Dr. Brown, for this incredibly informative program. And thank you to all of you who participated and submitted these great questions. Make sure to check out SHARE's upcoming educational programs and support groups, and follow us on social media as well. We also ask that you please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous, and we really use that feedback to influence and improve our programs. So that concludes today's webinar, and thank you again to all of you for participating.
Thank you so much.
Thank you, Dr. Brown.
Thank you.